And welcome to the Cardiac Sciences Grand Rounds for June 25th, I think. This is the pole position, the last Grand Rounds of the 23-24 Grand Round season. And we have quite a show for you today. I'm standing here looking at a room full of cardiologists, which doesn't often happen at Grand Rounds. Everyone's online, but it's great to see a full room, and we're looking forward to a great talk today. Today, we are hearing from the cath shock group. So this is the Calgary Cardiogenic shock team is going to be talking about the Calgary experience with shock team management. It's a tag team arrangement. A number of cardiologists are speaking. Greg Schnell, Ayaaz Sachedina, Jeff Shaw, Omid Kiamanesh, and anyone else speaking?
Yeah.
Ken Parhar.
And Dan Holloway from Zoom.
Oh, and Dan Holloway is going to come in on Zoom. So this should be great. We're looking forward to it. And I think we're starting off with Greg Schnell. Thank you very much.
Thanks, Andrew. Thanks for the introduction. You're clearly not an F1 fan because the last rounds is not the pole position, right? First gets pole. So we're the tail end. So it's my pleasure to introduce the concept of cardiogenic shock teams, the Calgary experience. And my role with you is to go over the role and benefit of a cardiogenic shock team. And my objectives with you in the first 10 minutes is to explain the rationale for a cardiogenic shock team with an illustrative case and explore some evidence in support of the cardiogenic shock team model. And before I start, I would like to acknowledge the hard work of Ayaaz to sort of push this whole concept forward. He's been the driving force behind our cardiogenic shock team, and over the last 3 years has really pushed this forward. So you're going to see this slide probably a couple times, and I just want to go over with you quickly the concept of SCI classification of categories of shock. It's shaped as a pyramid. A, B, C, D, E. A stands for at risk, B stands for beginning, C is for classic cardiogenic shock, D is for deteriorating, and E is a patient in extremis. As you move up the pyramid, there's a smaller number of patients in each category, but as you move up the pyramid, there's increasing mortality. Patients are sicker with more complex problems. And importantly, for the purposes of this talk, there's an increasing time sensitivity to make a decision. These are our sickest patients in the CICU environment and in the cath lab and potentially in Ken's world as well. A variety of studies over the last 10 years showing that as your SCI category increases, your mortality goes up. So if you look at sort of the light blue bar, that's your classic cardiogenic shock patient, has a mortality rate between 40 and 50%, depending on the environment. If you're deteriorating, that mortality goes up to 50 to 60%. And if you're in extremis, that mortality is 60 to 70%. So these are our sickest patients. We really need to focus on our resources on helping them do well. You'll be familiar with this sort of spiral, a diagram of patients who present with cardiogenic shock, and that unless you intervene, they're going to progressively deteriorate as they develop hypoperfusion related to myocardial injury. That leads to progressive acidosis, multi-organ failure, and then the patient starts to spiral. And you've probably heard repeatedly about the importance, or you've been said frequently, well, we intervene too late, right? So you've got to get the right patient and you've got to intervene at the right time. These devices and therapies that we're contemplating here are not without some downsides, right? They have complications and problems. They're expensive. They're resource dependent. And if we're going to employ them and deploy them, we have to do it at the right time. So these are all the things that we need to think about when we have a patient in cardiogenic shock. And it's not just thinking about what mechanical support device you need. You need to make the right diagnosis. And I'm not sure if one of my colleagues is going to talk about the fact that not all patients in cardiogenic shock are cold and wet, right? There's subtypes. There's renal replacement therapy because the kidneys are often not working. If they've had a neurological injury, they need temperature management and perhaps prognostication. They may have traumatic injuries from extended CPR. So a lot of these patients are almost like car crash victims. They may have bleeding from our interventions as well as medications. We are the GI/GU stress lab, right? Hepatic function may not be normal. We need mechanical ventilation and what type of mode of ventilation, nutrition, family meetings, palliative care. So all these decisions need to be made simultaneously And it's a lot for one individual to take on. So Copernicus said, to know what we know, to know that we know what we know, and to know what we do not know, what we do not know, that is true knowledge. And that's a fancy way of saying the only time you get into trouble in medicine is when you assume you know everything, right? And I've said that and lots of other people have. And so getting help in these patients who have a very complex acute problem is important. So let me just illustrate this quickly with a case. My colleagues, I think, are going to show you some examples of cases where things went very well with our cardiogenic shock team. I want to show you the flip side. This is a 50-year-old male who presented to a non-FMC site with chest pain for 8 hours. He was actually pain-free after a single spray of nitro in the emergency room. He had known coronary disease with an occluded right coronary artery with collateral, so at that time did not have a revascularization procedure, and he was treated medically, and he was compliant with that therapy. His last echocardiogram showed preserved LV systolic function. You can see he had a relatively low level troponin elevation. And so here's his ECG from his presentation. Looks like he might be a bit of a late presentation anterior MI with Q waves, but his troponin really wasn't that elevated. So he was admitted to the local hospital under cardiology, and as things tend to happen at 2 in the morning, the patient got up to go to the bathroom, got tachycardic, was short of breath, change in level of consciousness, and then arrested. And CPR was initiated. Oh shit, right? There's the ECG. That's the oh shit ECG. Here's the oh more shit ECG. And here's even more oh shit ECG. So that's kind of how his ECGs evolved over the course of 20 to 25 minutes after he's been resuscitated. He was in and out of this, required prolonged support in the local hospital over the course of a few hours to stabilize him. He was eventually about 4 in the morning shipped over here, gets here about 6 in the morning, has this angiogram, which unfortunately now shows his LADs occluded. The old right was occluded. And he's in real trouble. Shock team is activated. And unfortunately, it was felt that the patient was too far gone in terms of neurological injury and other multi-system failure to be supported, and the patient passed away. So here's another oh shit moment. As the CCU director, you get an email from the Office of Patient Relations called Private and Confidential a few months later. You hate to get these, right? There's always like, no, this isn't good. But fortunately, you know, in this case, we're able to go back to the family and say, because one of their questions was, why wasn't this gentleman offered a mechanical heart? And so here's a nice quote actually from Dr. Parhar, who reviewed the case, and we're able to say to the family in this circumstance, you know, this wasn't one person's decision not to support this individual. This was a whole team of physicians who have specialized training in the care of these patients, and we're able to say that this patient as a group decision was not offered mechanical support. So that's very helpful. So again, you're going to see lots of positive outcomes, but sometimes negative outcomes occur, and it's helpful to have a team that's made that decision to be able to offer that to the family. So here's the evidence. These are all retrospective studies. This is not prospective, but 4 studies all showing exactly the same thing. So on the left bar is your survival historically with cardiogenic shock prior to the introduction of a cardiogenic shock team at these institutions. And you can see that it's pretty uniform, that mortality is about 50%. And it all improved by the same amount in each of these 4 studies to improvement in survival to about 67 to 75% in those institutions after they instituted a cardiogenic shock. This is data from the Critical Care Cardiology Trials Network investigators, so the C3TN group that we're part of, looking at institutions with and without shock teams within the C3TN umbrella. And what they showed, if you look at the bottom right here, is that these were sick patients, right? Lactates were 2 or so, wedge pressures were elevated, cardiac indexes were all around 2. So they all were roughly about the same in terms of their degree of shock. Use of pulmonary artery catheterization went up in shock team hospitals. Overall mechanical support went down, primarily due to less use of intra-aortic balloon pump. Advanced MCS went up, and CICU mortality improved by about 6 to 7% uniformly in these institutes. What about the concern that too many cooks are going to spoil the broth, so to speak, right? If you put more than one physician in a room, what normally happens? they argue, right? If you put 5 physicians in a room, what's going to happen? It's going to take them forever to make a decision. Well, actually, that's not true. That if you get a good group, a working group together, what this study showed was that the time from decision to making a decision about mechanical support was comparable between shock team and control, and in fact, actually was a little bit less in the group that had a shock team. What do the guidelines recommend? Well, really, the Europeans, of course, they're always ahead of the game. They're the only ones that have published in this domain. And so what they recommend, obviously, is a hub and spoke model where these patients with cardiogenic shock are transferred to a level 1 center. They should have hemodynamic and PCI facilities that are available 24/7. They should have advanced MCS available. They should have on-site cardiothoracic surgery, and they should have a multidisciplinary cardiogenic shock. So we already have care teams for critical illness in trauma, right? There's a trauma team. We have a code 66 team. We have a stroke team. We have a PERT team for pulmonary embolism. We have a heart team where twice a week we get together and discuss patients that need intervention. So these are our sickest patients. Obviously, it makes sense to have a team to look after them. So there's no doubt that every team needs a captain, but I think we'd all agree that we're all happier when we work together as a team. So thank you very much. I look forward to the rest of the conversation.
Thanks, Greg. So going back to this model here, so I'm going to be talking about how we developed our shock team protocol here in Calgary. And so looking at patients who are progressing across up this pyramid, knowing that, you know, the top of the pyramid there is really the worst patient you can have in the cath lab, in the CICU, in the emergency department, anywhere. And so we know that as we move up that pyramid, that these patients, they present in a worse situation fast. And we know that, you know, despite our best efforts, despite everything going well, a vast majority of these patients are going to be very sick and their mortality is going to be high, even if everything goes perfectly from a shock team standpoint and initiation of care. But probably the biggest thing that we continue to learn is that there is a time sensitivity to making that decision, in the sense that if we delay too long, there is a window of opportunity that could potentially be compromised when a patient would be able to be brought back from that brink. And when we look at shock management in Calgary, this is not a new concept. For decades, cardiogenic shock patients have been managed really well here. But there were some cases where things didn't go as well as they could have, where the degree of the patient shock was sometimes unrecognized, because sometimes recognizing these patients is really challenging. And the consideration of some of these advanced measures was happening too late. And the other problem that was sometimes being encountered were that there were important subspecialty groups that could be part of that conversation and could help manage these patients that were not being appropriately involved or being involved too late. So when our shock team working group came together, initially started with all of these different groups: interventional cardiology, CICU, CV-ICU, cardiac surgery, and advanced heart failure. And it has grown. And now we've also had an opportunity to recently have some of our colleagues in cardiac anesthesia join us. And we're continuing to work together as a group to try and optimize our communication processes here. So when we discussed what we were looking for to develop our own local shock team, we were kind of hoping to achieve 3 things. We wanted to develop an activation protocol to guide not just our colleagues, but our trainees and allied health colleagues as well, on recognizing a patient who may be in cardiogenic shock and giving them an opportunity to involve the right people early. We wanted to develop an efficient method of communicating. And this was really important because if you think even from a cath lab perspective, before the shock team existed, if I wanted to put an Impella in a patient, I would have to first page advanced heart failure, have a discussion with them. And then a separate conversation by page would have to happen with the CICU physician. And those would be separate things happening in a serial manner. So you're losing time with that patient. And sometimes, you know, a great question by the first practitioner, someone else wants to ask it, and now there's a different person on the phone. So being able to come together as a group quickly was really important. And then finally, we wanted to be able to collect data for our outcomes in cardiogenic shock management and be able to look at it in a fashion moving forward. And defining these patients for all of us, for people who specialize in cardiogenic shock and deal with this on a daily basis, and people who don't, is really hard. And the reason for that is that the literature definitions for cardiogenic shock are encompassing, but they can encompass a lot of different patients. So the most common literature definitions for cardiogenic shock include a hypotensive patient, someone who may have pulmonary congestion, some sign of decreased end-organ perfusion, and that's sometimes done with laboratory studies or even just feeling your patient and noticing that the peripheries are cold. And then invasive hemodynamics are really helpful, but again, that's a patient who you've had a chance to put in an invasive line and measure these pressures on. And so I want to show you two patients here. So the patient on the left is someone who's having an inferior STEMI and cardiogenic shock. And the patient on the right is having a giant bilateral saddle pulmonary embolus. These patients on paper and on presentation to the emergency department looked exactly the same. ECG criteria, hemodynamics criteria, how they looked from a end organ perfusion standpoint. So they would both meet the definition for cardiogenic shock that are out there. But you can imagine that these two patients are very, very different, and their treatment is very different. The first patient needs that embolized mitral clip removed out of their RCA to make that. And the second patient needed a bunch of clot taken out from both of their bilateral pulmonary arteries. And yet they met the exact same definitions that were out there for cardiogenic shock. And so what do we learn from that? Well, cardiogenic shock is heterogeneous. There are patients who will look exactly the same, but their underlying cause is vastly different. And having multiple specialists on a call to help navigate not only the diagnosis, but the treatment is also really helpful. And so when we came up with our own cardiogenic shock protocol, the hope is that we would be encompassing enough where we would catch all of these patients who are in cardiogenic shock and be able to alert the cardiogenic shock team and initiate their management quickly. And you'll see that our criteria are actually a little bit more broad than some of the literature definitions out there. We don't have hypotension, for example, as a requirement because there are plenty of patients in cardiogenic shock who are not hypotensive. So for us, when we look at our protocol, so we start broad. We have a patient who the clinician at the bedside has identified that cardiogenic shock is likely the primary mechanism of what's going on with them. And then in a little asterisk there, we give a couple of suggestions. These patients often have ventricular dysfunction. If you have an invasive line, this person might have a cardiac index of less than 2.2, but those are not requirements. These are just suggested things for identifying this patient. So if the clinician at the bedside thinks, hey, this patient might be in cardiogenic shock, that's enough for us to be able to move on to the next box. They don't have to prove it. Secondly, that patient who they're worried about should have some sort of evidence of malperfusion. And so that can be, again, so many different things. You can have worsening kidney dysfunction, hepatic dysfunction, there are peripheral signs of decreased perfusion. You can have laboratory markers such as an elevated lactate. And then again, but again, none of these are requirements. These are just suggestions for identifying this patient. And then finally, if you're managing that patient or encountering that patient at the bedside and you're thinking, okay, I have this patient, I think they're in cardiogenic shock, I'm seeing signs of decreased end organ perfusion, and I'm thinking I'm going to have to start Levophed or some other inotrope. I'm thinking I might need a balloon pump or some other MCS device. That's it. That's all you need. Those three inklings put together, and we want you to call the shock team. I'm going to pass it over to my colleague Omid, who is going to explain how we do that.
Hey, thanks, Ayaaz. So after identifying a patient in shock, we built out a communication framework that we think is both simple and effective. So it starts with a clinician identifying a patient, and usually this would originate in the cardiac ICU. So they would activate the shock team by paging rapid and requesting a shock team activation, and heart failure would get on the phone. And then very quickly, in a matter of minutes, you can have 5-6 physicians on a real-time conference call to review the case, solicit input, and come up with the best strategy for the patient. And this can also be revisited throughout the day or night as the case changes. And you can see there's a number of different broad arms of therapy that a patient might benefit from. That could include medical therapy, which would continue, be continuation of ongoing vasoactives or a transition to palliative care. There's percutaneous VADs in the middle, which might require a different subset of team members, or then some of the advanced forms of mechanical support, which are much more involved. I think I really want to highlight here, there's not one therapy that's preferred over the other. That is not the objective. There's not even a desired outcome necessarily. I think the objective that we have is to just make really good decisions for these patients at a critical time. And so, I would define that as a very well-considered clinical decision that involves the perspective of, a multidisciplinary team of professionals. And I would say that there's often uncertainty for these cases. And so allowing us through consensus to increase the overall confidence in the decision and minimize uncertainty, I think is really the goal. And part of that is having a clear structure as to what we're trying to achieve for this patient long-term. And so it's important to be forward-looking and work your way backwards to determine the best therapy. And so if we just consider And this is a framework we often use in heart failure, but if we consider someone who is a potential VAD candidate, there's a couple categories here. On the far left, they might be clearly eligible for transplantation, which would be the best long-term outcome for someone, or they might be clearly transplant ineligible. And so if you're transplant eligible, then all the actions that we would undertake in general would be a bridge to transplantation as the best long-term outcome. Whereas if you're transplant ineligible, then they might be looking at long-term mechanical support or a bridge to recovery. And so the clinicians would need to make sure that that was something that was feasible. And then often we're faced with these rapid developing cases. We're faced with someone who potentially is eligible. And so they might have reversible contraindications, in which case you would say, well, this is going to be a bridge to candidacy if we can reverse some of these contraindications, or a bridge to decision if we still need to gather more information to determine the best treatment for the patient. And we have to remember that these are very fluid and dynamic cases. And so as someone's care evolves, they might transition from one strategy to another. Okay, and I'll just, Dr. Holloway is online here. So I'm just, Dan, I'll advance the slides for you whenever you request.
Okay, great, thanks. So that flow chart is great, and it kind of leads into the exit strategies. So ECMO is really great at curing CPR. In the immediate term, we get to take a step back, we get to take a breath, but it's not the end of the story. There's always going to be something else. And this is something that I think we all consider before we initiate ECMO, is we need to have a planned exit strategy. And if it's a patient where we can't think of a possible exit strategy, then there's a good chance that they're not a good candidate for ECMO, and it may not be beneficial. Next slide. So the possible outcomes, this was in that graph or that flow chart previously. Bridge to recovery, this is obviously the best possible outcome, and it means that hemodynamics improve and we can successfully wean. Transition to more advanced mechanical support, so that could be LVAD or a BiVAD. Transplant, or if a failure to wean or death or palliation are also possible outcomes. Next slide. So recovery and wean from ECMO, this is something that's considered. There's obviously many clinical variables that we look at. Decrease in normalizing lactate. If we have echo evidence that the LV and the RV are improving, we're seeing an increased pulse pressure, and we're having resolution of organ malperfusion. These are just some of the aspects that we're looking at to make us think, is there a chance as patients being able to come off ECMO? Next slide. So what are the chances of being able to wean ECMO? And this is variable. It depends hugely on the reason that the patient was put on ECMO. So what's the etiology of their shock? And the success reported, it does vary quite a lot depending on the center. But it's somewhere in the order of 30 to 70%. The predictors are well published. If a failure to wean, so if the ejection fraction doesn't recover, we're below 25%, both of the LV or the RV, that's a poor predictor. If they've been on a long run of ECMO greater than 7 days, or if they've required vasopressor support for more than 4 days, and if throughout this process they haven't been able to mount any pressure, those are all predictors of failure. So bridging to a VAD, so this, of course, this is something that we think about prior to the initiation. Are they going to be a potential candidate for a VAD? And the prevalence of this does vary also by center, but somewhere around 10% of patients on ECMO will proceed to receive more durable support. And this could be a medium-term support. So in our center, we'd use a CentroMag for either LV or RV or BiVAD, or all the way up to a durable HeartMate 3. Heart transplant is, of course, possible, and this is less common. In the literature, it suggests only around 5% of patients on ECMO will proceed to receive transplant. I wonder, though, if this will change, and with the increasing availability and prevalence of DCD hearts, hopefully in the next few years, we might see more greater numbers of patients that are able to go to transplant. And then, of course, death and palliation. Death on ECMO can occur for several reasons. Failure to wean ECMO. You know, if there's no other exit strategy, that's the end of the line. People on ECMO can also die of complications. That includes bleeding and sepsis or continued multi-system organ failure. And, you know, I think it's important to note that some mortality is inevitable. Even with well-planned exit strategies, that's just the nature of how sick these patients are. That's it for me. I'll pass it on to next presenter. Thanks.
Well, good morning, everyone. I wanted to highlight a couple of cases to illustrate some of the points that have been made by my colleagues from earlier this morning, and I completely agree with Dr. Schnell. It's oftentimes very difficult to make decisions about who should go on, particularly for advanced therapies like ECMO. So I'm going to show you two cases from earlier this year. These cases were almost actually sequential and came in January and February of this year, so you might recognize them. First case is a 54-year-old gentleman, unidentified, diabetic, obese, no known cardiac history, who was found in cardiac arrest at his workplace. This happened probably around 10:45 or 11 in the morning. The patient was last seen normal a couple of hours before that. The arrest was unwitnessed. The patient had 5 minutes of bystander CPR before EMS arrived. And when an EMS arrived, the initial rhythm was VF. Therefore, the patient was brought in to PLC and arrived there by 11:41. Over the course of the next while, there was intermittent return of spontaneous circulation for a total of 20 minutes. And at times when the patient would lose their blood pressure, the patient was found to be asystolic. More and more CPR was being done, and the decision was made to transport that patient to the cath lab. When the patient was seen in the cath lab, the patient was obviously comatose, the pupils were myotic, the blood pressure was 70/50 with a norepinephrine requirement that was fairly high, 0.8 mics per kilo per minute. There were anterior rib fractures that were noted on the chart. Now, a shock team consult was activated. There was quite a lot of vigorous debate about this patient, and the ultimate decision was to put this patient on with everything. What happened in the CVICU? Well, when the patient was brought over, there was a number of different issues that the patient struggled with. Number one, there was a large hemothorax. There we go. Two, the lactate never really normalized. Unfortunately, there was an infrarenal dissection related probably to the cannulation. And when the patient had a chance to settle in, the patient's pupils actually went from being myotic to enlarged, dilated, and non-responsive. CT scan was done, which showed pretty significant hypoxemic ischemic injury. And subsequently, the patient was examined and had no brainstem reflexes, and a nuclear scan was done, which demonstrated evidence of brain death. Now, sometimes in this scenario, you can consider the patient for organ donation. Unfortunately, the patient was so unstable after all of this that the organs were not supportable and was declined by the organ donation folks. Now, I'll contrast that with a second case, which happened shortly thereafter, and this was in spring of 2024. This is a 60-year-old gentleman who presented with an anterior STEMI, had a previous history of anterior STEMI back in 2019, and associated mild LV systolic dysfunction, and also had a known LV thrombus on anticoagulation. This patient was a diabetic, a dyslipidemic, and had hemochromatosis. This patient presented also with an acute coronary syndrome with 8 hours of chest pain. The patient presented in one of our regional centers and was found to have an anterior septal STEMI. Patient was aspirin and Plavix loaded, transferred here to the Foothill CICU, and the patient was actually stable enough where it was felt that the patient could have a cath the following morning. The patient was chest pain free at the time. In the cath lab, although the patient went unstable, the patient became unstable. There was an attempt to balloon the LAD. There was associated hypotension. There was some vasoactives provided, and there was a PA arrest. Shock team was activated. There was activation also of the Lucas CPR device, and the patient was intubated. Throughout this time, there was signs of life, although the patient was developing more and more signs of ongoing shock, acidemia, requiring bicarb. The patient was hypocalcemic. The decision was made after some debate to put the patient on VA ECMO. This This allowed us to facilitate intervention on the heart. And so there was initially an attempt to PCI the LAD. The patient unfortunately had no reflow and subsequently became quite unstable. With the ECMO, however, the patient became much more stable. A drug-eluting stent was able to be placed in the proximal LAD, and the patient moved over to the CVICU, where the patient was actually able to recover quite a bit of pulsatility and was decannulated from ECMO on the second day. The patient was extubated on day 6 and discharged home subsequently from the ward. So I highlight these two cases just to show some of the complexity. They, much to Ayaaz's point earlier, they had somewhat similar presentations in that they both had evidence of cardiogenic shock and also had cardiac arrest. However, there was a lot of subtleties and differences. One had a prolonged downtime, an out of hospital unwitnessed arrest. The other patient was an inpatient who had a witnessed in-hospital cardiac arrest. And in one case, there was probably no opportunity for significant revascularization. In the other case, there was a likely reversible etiology. So really important, and again, highlights the importance of having a shock team and also having thorough discussions that can oftentimes lead to good decisions. I think probably one of the biggest challenges and also one of the biggest growth opportunities for us will be to continue to calibrate our decision-making with review of cases like this to better offer the right treatment to the right patient at the right time. And then I'll just finish with the last slide here, is just to sort of show everyone and give everyone a flavor of what ECLS activity is like in Calgary. Obviously, over the last 10 years, we've had an increase in the amount of ECLS activity over time. We're somewhere in the neighborhoods of 35 to 40 cases a year. The majority of those cases are VA ECMO cases, and the majority of those VA ECMO cases are in fact post-cardiotomy or post-cardiac surgery. The minority of cases are patients who are in cardiogenic shock for a variety of reasons. It could be myocarditis, it could be patients in the cath lab, it could be overdoses, those sorts of things. We do have an increasing number of patients who undergo eCPR or undergo VA ECMO while being under cardiac arrest conditions. But many of these patients are actually from our accidental hypothermia program, where patients are found hypothermic, and because they're hypothermic, we put them onto VA ECMO to try and facilitate rewarming, and that program's actually done quite well. And so with the remainder of the patients, it requires really careful selection, much like the second case that I presented to you. And with that, I'm going to hand over to my colleague, Dr. Shah, who's going to tell you a little bit about ICU.
Thank you, Ken. It's my pleasure to talk to you about the experience within the cardiac ICU and the shock team. When we initiated this process in 21-22, we wanted to have an ability to assess how we were doing at the start and to use data to provide us feedback as we move forwards. So we joined the Cardiac Critical Care Trials Network. This is a network of up to now 40 units of excellence across North America, including 7 here in Canada across 5 provinces. The data submitted is a 2-month snapshot from each of those units every year of consecutively admitted patients to the cardiac ICU. And then there's really 3 goals of the network. One is to provide data back to those centers for quality improvement processes. And then as a group to do combined research. There's now over 30 publications that have come out of this group. And we have started to collaborate, including on a paper just recently published, and then combined teaching initiatives. And so when we started, this is data I'll show you from 2022. Unfortunately, in 23, there was actually a legal issue at the host site in which they could not accept our data. And so we had a missed year, but are back up and running in 2024. So I just caution you that this is about 150 consecutively admitted patients with less than 30 in cardiogenic shock. So it's a small data set, but gave us early clues as to our starting position. So you can see here that our overall success for hospital mortality and CICU mortality was quite favorable compared to the group. But when you split that between our less sick and more sick patients, the sicker the patient gets, the worse we do in comparison to our peers. And so this is showing us the SOPA scores. As the SOPA score increases, illness increases. And as that score gets into the 7 to 9 range, our outcomes are unfavorable. when we look at a more granular level to understand what types of patients we're succeeding on and where might be areas of improvement, we can see that STEMI patients, heart failure patients without shock, including valvular heart disease, we do very well with. But shock, cardiogenic shock, and the post-cardiac arrest patients who are mechanically ventilated, there may be areas for improvement on. When we look at cardiogenic shock in particular, we can see that as the patient goes from SCAI stage B, C, D to E, we actually do worse as the degree of cardiogenic shock gets worse. And again, I caution that this is a very small data set and that 1 or 2 cases could really influence this quite significantly. Nevertheless, it made us look at the data and say, is there any reason why we could understand how we might differ from some of the other centers in the way that we're providing care? And when we look at everything from vasoactive use, mechanical circulatory support use, hemodynamic monitoring, we actually look identical to all other centers. So there wasn't a clear signal about, are we using a different toolkit? We're clearly using the same toolkit at the same rate as other centers. I think this raises the question, well, is it our processes of care that need improvement? Is it the timing of our decisions? Is it the way in which we make decisions together and the flow of care that needs to improve? And that's where the real motivating force to say, hey, this shock team could really provide our patients something, particularly in our center. Looking at our own unit, our cardiac ICU, we have about 2.7 cases that meet criteria for our shock team activation per week. Of those, over the last 85 weeks, about a half are being activated upon. So we're capturing a half, but missing a half still. So still areas of improvement with how we activate the cardiogenic shock team. There is a trend for improvement over time, which is nice to see. There is also clearly different reasons why someone might not activate the shock team. And there are clearly examples where someone is 80 years old and has changing goals of care, and it clearly is inappropriate. We don't capture that in granularity here. But that's not the whole part of the story. And we can see that even within our group, we have super activators and modest activators of the cardiogenic shock team. So some of it is clearly not patient driven, but as it relates to the provider. And I think that there are cases in which we say to ourselves, well, I know how this is going to go. I don't want to bother my colleagues with this case because I know the outcome. And I just wanted to share a case I had where I thought that was true, but I think the cardiogenic shock team saved someone's life. This is a 69-year-old presenting with a late anterior STEMI and cardiogenic shock who comes into the cath lab, discovered to have multivessel coronary artery disease and high filling pressures and a terrible heart. No mechanical complications are identified. And out of the cath lab, the shock team is activated. A group decision is made that the patient should have hemodynamic monitoring within the cath lab, and a decision should be made for whether that patient meets criteria for support. There was several features up front which made the case challenging. The patient didn't have good targets, obviously, and were late presenting. And so a decision after the hemodynamic monitoring showed a cardiac index was not as bad as we might have thought, was to put a balloon pump and give the advanced heart failure and cardiac surgery team a chance to meet this patient and see what may be options for them. And that we would reconvene in 2 hours after the patient was in the cardiac ICU and assess how we were doing at that point in time. So the patient was admitted to the cardiac ICU and continued to decline. The surgical team assessed that they weren't an optimal candidate for surgery due to poor targets. They weren't a great candidate for long-term support and thus weren't a great candidate for ECMO. And I honestly turned to a resident at that point and said, I don't think that this is going to go so well. And had it not been for the process already in place, I may have called the family, I think, in honest reflection and said, let's go a different route. But we had a second team meeting planned. And so I called the team back and we reviewed the case together and all agreed, no, they really weren't a candidate at this point. They did not meet criteria for long-term support, but that maybe we should offer them upgraded bridge to recovery and reconsider revascularization options if we could achieve hemodynamic stability. So the patient went back to the cath lab to have an impella placed. An impella is a more significant hemodynamic support device, which is a short-term VAD. This is the original angiogram showing those 4 targets. And this is with the VAD in, showing how that even just with increased flow, you can see much more perfusion through the coronary arteries. And the patient was brought back to the cardiac ICU and did stabilize. Their lactate cleared. And then we did make a decision that they could be revascularized. They did have multi-vessel PCI performed. And over the course of the next weeks, the impella was removed, dialysis was started and then stopped as the kidneys recovered. The patient was extubated, they were transferred to the ward, and they started physiotherapy with a plan to go home. So it's just a really clear case of how a team-based process, and the process itself probably saved this patient's life in the face of a decision that may have gone the other way. So what are our future directions? Where are we at and where do we plan to go? Well, we would really like to have all cardiogenic shock patients captured within the Cardiac Critical Care Trials Network. There's 2 classes, the 2-month snapshot, but also an annual cardiogenic shock registry. We have raised funds to hire a part-time data assistant, which we're in the process of doing to try to capture cardiogenic shock patients throughout the year within the registry and get quality improvement data on those patients. We want to increase our research participation through this organization. We have our first co-authorship. One of our fellows just met with the head of the C3TN and is going to do their own prospective trial that we'll participate in. And so we're increasing our contribution to research in the field. And then third, we really have this escalating amount of educational initiatives that we're a part of. Of course, Ayaaz leads the Cath Shock Conference annually, which is a great educational event. We run a 4-part cardiogenic shock simulation series for our fellows. We've initiated a quarterly case review series just within the working group, but that's going to expand out to all the ancillary groups in the fall. We've started a biannual journal club and had our first instance of that several months ago, reviewing the danger shock trial. And so as we go forward, I think the buy-in to the concept will increase over time, and that we may gain the confidence then to offer our services beyond the cardiac ICU to the emergency room and other ICU departments when we feel like we've met that threshold. So with that, I thank you for listening to our presentation. We'll open it up for questions for all the speakers today.
Okay, thanks. Thank you, Jeff. Thanks very much to everyone who spoke. That was a wonderful round. And thank you again for everything you have done with the shock program. Ayaaz, with your Cath Shock Day, as Jeff pointed out, that's been a wonderful thing. And the program is wonderful for Calgary. I'll start off with the first question. With regards to patients presenting at our 3 other, how do you see that interaction with shock team work? I like that Ken presented 2 patients that have presented at other sites. And I know when people are here at the foothills, it's easy for the red team doc to activate the cath team, and that pathway is very clear. But if someone presents to the Rocky View or South Health campus, how do you see that activation and that pathway working most?
Yeah, so the pathway that would involve activation, so the activations occur through the cath lab, CBICU or CICU, and so one of those responsible physicians would be involved, and likely from another cardiology site that would either be through the cath lab. If the patient needed to come emergently to the cath lab doc would be called and then subsequently activate the shock team. Or the patient was being transferred to the cardiac ICU, the red team doctor, orange team doctor would be called and then subsequently activate the cardiogenic shock team. So it'd be still facilitated through one of the activating units. Clearly, the patient would need transferred to one of those spaces anyways, and so it'd be through that transfer process, the shock team would be activated. The Rapid is a really nice tool to have that happen quickly. And so we're really encouraging the use of Rapid because that allows for immediate activations. We've had a number of examples of that where patients are coming from outside centers, even Lethbridge, Medicine Hat, where the call comes in and the accepting doctor says, well, this sounds clearly like a case of cardiogenic shock. Rapid, can you just involve the shock team right now on this call right now? And then that solves the delay process. And we've had a case that I was involved with that a patient was immediately placed on ECMO on arrival because it was so clear that they had cardiogenic shock and you know, the cause had already been outlined at the referring site. And so even before arrival, the teams were all ready.
Why don't we start with Brian?
Thanks. Great presentation, everyone. My question is for Dr. Parhar with regards to ECLS. So for STEMI call, we've noticed an increased number of activations for patients that are post cardiac arrest. And, you know, unfortunately, a lot of them are the socially marginalized population, overdoses, the unhoused. And it's a bit of a difficult decision-making process for us because some of them are just widespread massive ST depression, or they may have ST elevation that could be from spasm, from epi. And so for like your ECLS activations for hypothermia that have gone up in the past couple of years, like what proportion of those are that type of population? That's the first question. And the second is for the ECLS program, do you have any data for like survival to hospital discharge? Because in other centers like Vancouver or Montreal, they've launched these programs a few years before us, but then their outcomes for survival aren't that great.
Yeah, those are really great questions. So to answer the first one, with accidental hypothermia, typically those patients, and when I'm speaking about hypothermia, they're 22 or 24 degrees core temperature. So they are cold. And the idea there is that they become so cold that they then, as a secondary effect of that, they've actually suffered a cardiac arrest, not the other way around. And so in those cases, the brain is actually fairly well preserved, and they actually remarkably have a great outcome. Like we're probably batting a 45% survival to hospital discharge for these patients. We had a patient that had 3 hours of CPR. She had come home from the bar on her driveway. She basically fell, passed out in her driveway, was 22 degrees all night. And she had 3 hours of CPR, got taken to the wrong hospital before she was brought to the foothills. And she, once we warmed her up, she actually woke up, and was neurologically intact within 6 hours. So they have a remarkably different natural history than other patients. Unfortunately, with those other patients, if they developed a cardiac arrest directly from their overdose or whatever the inciting factor is, then they arrest and then they get cold. Then it's like any other out of hospital cardiac arrest where the outcomes are not good. So I would agree with you with respect to our colleagues in Vancouver, and Brian Bruno, who you probably know, had led an eCPR trial for this reason, because they had modeled out how many cardiac arrests they get for out of hospital cardiac arrest, what their possible number of lives saved was. But what they found in reality was that for these non-hypothermic arrests, the survival rate is really, really low. And it's a really challenging population. And I think as a CV intensivist group, we probably come across as the most pessimistic with these types of patients, but it's because our own outcomes mirror that. Going back 10 years, I didn't present the survival data, but eCPR outcomes in ischemics, like we're probably like less than 10%. That's why that patient, the second case I presented with Dr. Russo's here, I think that was a great example of putting some thought into what the etiology is. It was a reversible cause. The CPR, although it's a concerning risk factor for a poor outcome, in fact, that was a case where we could actually make a difference, and it was reversed. Contrast to that first case I presented. So I think these cases, it just illustrates that they're really complicated. I think having a group discussion is really important. I think that's probably the most important thing, as Jeff has also pointed out with his cases, that the really important discussions that need lots of people in the room to, and everyone's looking at it from a very different lens. I think all those opinions are very important. We also don't want to leave, you guys in the cath lab have a really tough job as the interventionalists, because it's kind of like you're a patient in there, and we're all flying in to give an opinion, but you're kind of left holding the buck stops with you. So I feel for you guys, and I hope you guys feel like you're supported by us in those decisions. Sometimes, despite all of our best efforts, we just can't pull patients through. To answer your question.
I was curious because obviously patient selection very important for MCS and the calibration process is obviously important too. So I just wonder how we go about that calibration because I remember when I was in internal medicine residency, we used a similar logic with CTPEs. Some people would say every CTPE that I've ordered has been positive. And then on one comment, the staff at that time said actually only 30% of CTPs that you order should be positive if you have the high index of suspicion. If 100% are positive, then you're probably not sending enough people for CTPEs. So I feel like in these cases where we show a success and a failure, is the failure to survive a failure of the decision, let's say, because it would be kind of akin to a number needed to treat. In order to get that second patient, we need to treat patients that won't survive potentially. So I just wonder how we do it other than making the calibration based on outcomes, which might lead us, these patients have a high mortality to begin with. So if we could reduce the mortality from 100% to 70%, that's still very good for the patient, but for the program, the optics might be 70% of our patients are dying. So how do we get over that, in a disciplined way?
Yeah, I think that discipline and using data as a feedback is a really good way for us to try to discern those things. And so just in the example we've been talking about, so these cases were presented at our internal case review, and then we looked at data in terms of, can you use data at the time of presentation that someone comes in with an out-of-hospital cardiac arrest to predict their survival? And it turns out, you shouldn't do that for applying care in general, but for applying a very selective, resource-intensive item, that it probably is appropriate to do that. We validated different scoring systems within our own data, and can internally agree that maybe there is criteria. The cardiac arrest hospital prognosticator score has been internally validated, where that, if it's really clear that the prognosis is detrimental up front, that we shouldn't offer that patient very intensive, resource-intensive support. And so, yeah, no, I think your point is well taken, that you really have to reflect on these cases and have a mechanism to do it. I think these case rounds that we're doing and using data to support the group calibration of where we would apply these services, using data as the way to guide us, is the right approach.
Yeah, I was just going to add to that. I also think that survival isn't always the only or even most important outcome. And so a lot of this work has been done in durable MCS. And so we look at patients getting evaluated or referred for left ventricular assist devices. And there's the randomized controlled trial looking at multidisciplinary workup, including palliative care, as part of the consultative and decision-making process. And what you learn from that trial is that if you go through that process, less people go on to get a VAD, but all people have greater confidence and satisfaction in their decision. Actually more people dying, but more people satisfied with that outcome. And so I just think that's the important reflection piece, that in our high intervention, highly focused field, we should maintain a broad perspective on just the humanity of what they're going through.
And it might modulate the graph that you showed about the outcomes in hospital. Like maybe a good palliative care program will increase mortality in hospitals simply by giving people the outcome that they want. And it would look like mortality is higher. But the one thing that I've had, I think in the code shock definition, it would be really nice to have a definition of near certain death, let's say. Like when we have let's say we were called for a code shock, just to label patients one way, regardless of what we decide, to say, if it wasn't for MCS, I believe that this patient's risk of death would be more than 95%. And then we can see how many patients we labeled that way and how many die. I mean, some might die because of their goals of care or their values. But those that are still R1, how many die with MCS versus without MCS? Because I think that would give us an idea as to what, I don't know if that definition exists, but I think it would be very practical and useful.
Why don't we do some of the chat questions?
Yeah, so there is, there's a question from Tim Prier. Do you see a need for a specialized inter-hospital transport team, particularly when it involves greater distances? I think that when it involves greater distances, we do have one. The STARS team is that facility hospital transport team, and I know I'm grateful for their support. I do think they do an excellent job of providing enhanced care, including where appropriate physician supported transport. That's not done within the city. So if the reference was from South Health Campus to Foothills, we don't have that capacity, but the distance is likely short enough that that resource is not required. Any other questions? Yeah.
Just a comment and a quick question. One, I mean, this is a lot of work and, I think you guys should be very proud that we could get this going. It's multiple groups, multiple environments, multiple technologies. The question I have is on the graphs you showed from the Cardiac Critical Care Network. And I might have missed some of the graphs, but it looks like on the one actually those percent admissions where we didn't look so great. Is that true for, let's say, if you look at 30-day mortality or hospital discharge, is our numbers sort of still looking not as good as the national average or something like that?
I can back to that. What I was showing was hospital mortality, and then it is 30-day mortality. So it's
okay, it was 30-day mortality. Okay.
Yeah. Look at this. This is our
Okay.
mortality.
Yeah,
That's
okay.
This is hospital mortality in this. This graph here is hospital mortality.
And it clearly seems to be the shocky patient for that.
Well, the sicker patients, right? You can see however you classify it. So this is SOFA score. You just look at the groups that are sicker by their, the mechanism, or within cardiogenic shock, the sicker patients. As their patients get sicker, in this initial snapshot, our outcomes get worse compared to other centers.
If you look at those numbers, they're almost exactly the same as those 4 retrospective trials, right? Where the pre-cardiogenic shock mortality is. And in all of those trials have improved too.
Then is it right to assume that most of the other centers in the CCC and shock teams and we're late to the games?
Well, there's probably a mix. Probably about half of the sites in C3TN. Not all of those sites will have a shock team.
But I do think those sites are more forward thinking. I mean, there's thousands of units in North America, right? That's a very select.
It's only 45 sites, right?
Yeah.
All primarily.
Yeah.
Well, and most of the data,
like
most of the data comes from the early adopting sites. And so you're looking at 30,000 patient encounters. Most of that data comes from the first group. And as units join, they develop shock teams. They tends to be a
Sort of
something that happens together.
Enters the data.
Right.
As you say, it's also a small data set.
Very
We don't have
Yeah.
variance there, so it may help.
Just a little plug, if anybody's interested, go back to your last slide, that position that we have, 2 FTE, if anybody's in the room is interested. We got to do our data by the end of the summer. And so please see Jeff and Andrew immediately after this meeting. And you'll have a 0.2 FTE by tomorrow.
Like too many cooks in the broth. But getting a bunch of physicians together is like herding cats sometimes. So when your call goes out, how many answer and how many are necessary on the shock team to answer? Because we're all busy, you're all going to be away or doing other things. So what makes the critical number to answer this call?
Well, and that's why we allow for physician discernment and a progressive activation strategy. And so when we look at our actual activation, we can see that initially the call goes out to 1 or 2 physicians, and then other physicians are added based on the decision-making process. So if it's going to be even a consideration of ECMO, well, then of course we need our surgical colleagues, our CVICU colleagues, and cardiac anesthesia involved. If the case is clearly one in which the decision process is that maybe we just need a balloon pump and an hour of recovery after revascularization, we're not going to involve all of those colleagues and interrupt their day. And so we've designed a process that can facilitate the inclusion of physicians as those decisions are being made.
But our callback rate is near 100%. I mean, these are services that are on call to help look after critically ill patients. It's not, it's just a better way of communicating in their already existing roles, I would say.
Rapid is calling the person on call.
Rapid's calling personal call and says shock team call. So you would respond to that faster even than, unit 81, low potassium order, right? That maybe has, maybe has real time, right?
I thought Jeff's, like, the case that Jeff presented really highlighted it, where he basically used every box here. So the initial call that he did didn't involve 6 practitioners. It was the heart failure physician and myself, the interventionalist. And then as the patient's case dynamically changed, similarly, the number of people on the call dynamically changed in subsequent shock calls.
So there's more members than you guys involved with the shop.
Yeah, it's
All the cardiac sciences, basically all the cardiac sciences, right?
It's that higher community service.
You find like it is an expert opinion exercise and different experts have different opinions. And because there is no landmark trial before danger basically showing that one specific therapy is useful, I feel like the process in certain scenarios by chance can feel almost like a jury process where you have almost bimodal opinions. So it's interesting to see like what do you do in that situation where you have to come up with a consensus in a timely manner, and then somebody says, well, there's no evidence for this, because it's very difficult to do in the middle of the night. So that's part of where I feel too many cooks in the kitchen can create a problem if based on the lack of randomized control trial data.
I think just one last comment is, I think the one thing though in Canadian public healthcare system is that we don't have unlimited resources, and sometimes one of the considerations is rolling the dice on something that has no evidence. There can be hesitation because what that may mean is that a surgery the following morning is bumped. A patient that's been patiently waiting for their aortic valve replacement gets, there's a lot of knock-on effects. And so there is a bit of, medical justice that has to happen, unfortunately, because we can't, it'd be great if we could put 100 patients on ECMO for ECPR, but we just don't have the resources to do that. So that's just one other consideration as I'm sitting next to our boss here.
Okay, and just a couple of quick questions that can be answered quickly here. Can you comment, are fellows encouraged to call the shock team, or should they go through the right physician?
So that is, we'd still like them to involve the red physician, and we think that physician needs to hear about that case immediately anyways. And so if, we don't want the attending physician to be the last one to discover that there's a critically unwell patient under their care. And so we feel like they should be immediately aware of the patient. And if they want the fellow to activate the call with their consent, that's a different story. But yes, we'd like the attending physician, whoever that is, to be the first one aware of the case and to use their discernment about the shock team.
Well, just to go one step further, like we have posters around the CCU to empower the nurses looking after the patient to identify these patients that meet criteria and then rapidly escalate that as well. So we definitely encourage the communication.
Yes, absolutely.
Okay, give the last word to Dean here. Cath lab catastrophes are the most difficult to deal with and are often very survivable if MCS is applied in a timely manner. What ideas are being considered to facilitate support in these circumstances?
But Ayaaz as well.
Yeah, I think that's a great question. And it comes down to us looking at how to optimize all the different aspects of that pathway, because it's not just a matter of putting the patient on an MCS device. I think the often critical point is identifying that right patient. And to everyone's presentations here today, sometimes we don't identify correctly when we're in isolation, and having that team-based approach is really helpful to help tease out the patient who has a chance. And if there are going to be those patients who we all agree are wonderful candidates for MCS, and some of those patients are still going to pass away, unfortunately, just as a natural history of their illness. But it's not just a matter of saying, hey, we have to be faster at putting in Impellus. I think what we constantly do is look at every step along the way, starting from the patient in the emergency department, the ECG that comes through, the story we get on the phone. And if we can optimize every single aspect of that patient journey, then the shock team activation and the eventual MCS deployment, that becomes part of that optimization. And as a group, that's what we are trying to do at every meeting that we have as a shock team working group. And it is a lot of work to involve so many different services. And sometimes the decisions don't just involve the 6 or 7 or 8 of us who are sitting at the table. It goes to a division level. And that takes time, but we're constantly working at it.
Guys, with that, I think we will close. We're top of the hour. So thank you very much.
Literally.